So I told you were going to get sick of me, but I'm back again. And so this...
Is that why we turned the lights down? So
yes, there you go. You could hide me. This next talk is really building off Heather's talk and to also get it started thinking about some of the blood-based biomarkers. Some of you have heard this before. Again, we're trying to get everybody on the same page, so just bear with me for those that have heard me talk about this before. So these are my disclosures. Really, the technological advances that over the past decade, less than the past decade, that have led to the development of blood-based biomarkers are just an incredible accomplishment. Current biomarkers that are clinically used, such as CSF and amyloid PET, are invasive, they're costly, and they're generally not easily accessible, particularly for more rural areas, as well as was just at the Alzheimer's Disease International Conference, and also not as accessible in many countries. There have been multiple studies that have shown the potential clinical utility of the plasma blood biomarkers, such as amyloid beta 42:40 ratio and phosphorylated tau 181 or 217 as biomarkers, accurate biomarkers of Alzheimer's disease pathology. And some of these biomarkers are available clinically and are being used. And in fact, immunoassays right now are reimbursable by Medicare and other insurances. However, the vast majority of studies to date that have looked at these biomarkers have been research studies that have focused on white, younger, for example, low 70s, and higher SES populations. They're also generally healthier. So there's an urgent need to understand how these biomarkers can be used, how they can be interpreted, and what factors might affect their interpretation in the general population. Now, Heather has already touched on this, so I'll just go over this briefly. But again, as I mentioned, most of the research to date has been done on younger individuals, again, typically early 70s. But when we think of the typical dementia patient that will be presenting, the average age of dementia onset is about 83 or 84 years, or at least in terms of diagnosis. And as Heather showed, 60% of older adults with AD have 3 or more chronic conditions. But notably, this percent is much higher in underrepresented minorities and individuals of lower socioeconomic status. Further, these chronic conditions we know can affect the expression of AD pathology and clinical symptoms. As a result of these chronic conditions, as well as polypharmacy that go along with the chronic conditions, it's very difficult to diagnose dementia and dementia type in primary care, as well as to predict disease progression. It's currently estimated, as was said before, that about 50 to 70% of symptomatic patients with ADRD are not recognized or incorrectly diagnosed in primary care. And unfortunately, there's a limited capacity of ADRD specialists. And so as we go forward, a lot of the diagnosis, particularly as we now have Leqembi, we have other new treatments coming down the road, will have to occur in primary care, as many individuals either aren't referred to specialists or the wait time is so long that by the time they get to see a specialist, they may no longer be eligible for some of these treatments. So in the next couple slides, first I'm going to talk about some of the comorbidities and medications that can affect the interpretation of these biomarkers in light of thinking about multiple chronic conditions. And then I'll just have an additional slide talking more about some considerations for implementation that I know others will expand upon throughout the day. So as an epidemiologist and somebody who for past 20 years have been very interested in developing blood-based biomarkers, I grew up in a rural setting and realized that this is really a way to potentially help diagnose patients. But it's also important to understand how these biomarkers look in the population. So using the Mayo Clinic study of aging, we started to examine the effects of a variety of conditions on these biomarkers. Now, I know some of you have seen this before, and you can close your eyes and take a rest break for a second. But for those that haven't, this graph shows the association between p-tau 181 and p-tau 217 in relation to a whole host of chronic conditions. And 181's on the left, 217 on the right. It's basically the same association, so I'll just be talking about these in general. In the black is unadjusted, and in the red is age and sex adjusted. And just to orient you, on the bottom, this is the difference in the plasma p-tau levels between individuals who are amyloid PET positive compared to amyloid PET negative. Now, in contrast, what we found was that if you look at individuals with chronic kidney disease, the difference in p-tau levels between those with versus without chronic kidney disease, stage 3 or greater, is almost the same as the difference between those with and without amyloid PET, or elevated amyloid in their brain measured by amyloid PET. Similarly, we also found elevated p-tau levels in those individuals who had a history of stroke and a history of myocardial infarction. Now, even when we exclude those individuals that are amyloid PET positive, you still see the same difference in plasma p-tau levels for those with versus without chronic kidney disease. In further analyses, we also looked at plasma amyloid beta as well as NFL, which is shown in this publication as well. And again, chronic kidney disease is particularly associated with higher levels of the amyloid beta 42 and amyloid beta 40, and also borderline higher levels of the amyloid beta 42 to 40 ratio. Again, we also do see some effects of vascular risk factors on amyloid beta levels. Now, I want to point out that with chronic kidney disease, there have been many studies that have replicated this finding. Most of the studies have looked at chronic kidney disease as a diagnosis and their effects on the blood biomarkers. But as you can see from this graph, there's actually a very strong linear relationship between renal function as measured by eGFR and some of these blood biomarkers. So the line here is highlighting kind of the normal range. So below an eGFR of 90 is when you start to consider chronic kidney disease and diagnose at least stage 3. And you can see even within the normal range of eGFR, there's a very robust correlation between eGFR and these blood biomarkers. Now, in terms of diagnosis, so a lot of the work that has been done on chronic kidney disease and eGFR have been observational studies. And studies have reported that when you adjust for chronic kidney disease, there still is an association between the biomarker of interest and cognitive decline, or the biomarker of interest in, say, amyloid PET or CSF amyloid. But that is on a group level. And there's also some consideration that chronic kidney disease may not actually be affecting Alzheimer's pathology. And so what does this really mean on an individual level for somebody that's coming into your office or a patient that is presenting? And I think this next example gives an idea of what some of the negative effects may be. These are some graphs of unpublished data in collaboration with Melissa Murray from Mayo Clinic Jacksonville. And we were interested in looking at the relationships between the plasma biomarkers and Alzheimer's disease pathology at autopsy. And interestingly, when we first looked at this, so we have Thal phase or amyloid plaque on the left and Brock staging or neurofibrillary tangle staging on the right, we found that the person that had the highest plasma p-tau levels had moderate amyloid pathology, but very low neurofibrillary tangle pathology. So we went through the medical records because I was trying to understand what this meant. And we found that 2 weeks before they underwent the study blood draw in their medical records, they had a serum creatinine level of 3.7. So this person had fairly significant chronic kidney disease. And so without the knowledge that chronic kidney disease can elevate these levels, this person would have come in and been diagnosed with Alzheimer's disease when in fact, based on the pathology, they actually didn't have significant Alzheimer's disease pathology. Now, there has been work suggesting possible ways to mitigate the effects of chronic kidney disease on those biomarkers. Here's a very nice example that looked at whether the ratio of non-phosphorylated to phosphorylated plasma p-tau 217 would be better. And we do see both in cognitively impaired and cognitively unimpaired individuals on the top row that, again, chronic kidney disease affects the plasma p-tau217 levels. But when you look at the ratio, it's not as affected. And in fact, there wasn't a significant difference. So there are some suggestions that the ratios may be better. Although I do want to point out, Anne Murray and I and Joanne Ryan have a grant looking at the Esprit study and biomarkers. And so we're looking at our first 12,000 individuals at baseline. And among those individuals, we still see a very strong association between amyloid beta 42 and 40 and chronic kidney disease. So the ratio is not totally getting rid of that. Now, I've already shown you this graph focusing on some of the vascular biomarkers, but I also want to highlight that there is an association between BMI and these measures as well, such that increasing BMI is associated with decreasing levels of plasma p-tau variables. Again, this is something that has been replicated in other studies, as is shown here with BioFinder, where, again, we see that increasing BMI is associated with decreasing levels of not only p-tau, but also amyloid 40 and 42, NFL, as well as GFAP. So what might be the reason behind this association? Well, I think the best study on this to date, and really the first study to examine this association, was a study of multiple sclerosis patients and controls. And they had found that increasing BMI was associated with decreasing blood NFL levels. They further found that with increasing BMI, of course, there's increasing blood volume, and that this increasing blood volume was directly related to the decreasing NFL levels. Now, notably, similarly with chronic kidney disease, this is a peripheral phenomenon, and so there were not any associations between BMI and CSF levels of NFL. Just to give another example, because I think this is the nicest example showing the effects of BMI, Rebelos and colleagues looked at the effect of NFL and GFAP related to BMI. And they looked at this among individuals that were undergoing gastric bypass surgery. So individuals that were with obesity, undergoing gastric bypass surgery, had a mean BMI of 41 at baseline prior to surgery. And interestingly, when you look here, again, those individuals that were obese had significantly lower levels of NFL and GFAP compared to lean controls. However, roughly 6 months later, when average BMI went from 41 down to 29, you can see there was a great increase in NFL and GFAP levels, such that they were then similar to those individuals that were lean control at baseline. There's also been many associations between blood amyloid and cardiac conditions. And Neelam, this is for you, as we've talked about this at ADI last couple days. So amyloid beta accumulates in the hearts of Alzheimer's disease patients and induces AD-related cardiac amyloidosis. Recently, there have been a couple papers that suggest that higher levels of plasma amyloid beta 40 and 42 are associated with risk of incident heart failure. There's also recently been some suggestions that certain cardiac medications can affect these blood biomarker levels. So, for example, sacubitril, also called Entresto, has been found to lower the amyloid beta 42 and 40 ratio, but not the CSF amyloid beta 42 to 40 ratio, again, having a peripheral phenomenon. And so on the bottom here, you can see from the study by Brum and colleagues, again, those on sacubitril had elevated levels of amyloid beta 40 and 42, but they had significantly lower levels of the 42 to 40 ratio. Just note that, it says 40 to 42, but that's a misprint there. Now, this particular study also looked at the other biomarkers, and they did not find that sacubitril affected plasma p-tau217 or NFL. So it's possible that in individuals with cardiac condition, p-tau would be a better biomarker. But in some of the work we and others have done, there are associations between p-tau, as we showed with history of MI as well as stroke. And there's also some very significant associations between p-tau and white matter hyperintensities that we still need to try and understand. So in summary, I've shown that chronic kidney disease increases Alzheimer's disease blood-based biomarkers, and obesity is associated with decreased levels of these biomarkers. As we think about the interpretation of the blood biomarkers in light of these chronic conditions, I think it's really important to try and separate these conditions into those that have physiological impacts versus those that are risk factors. Risk factors for the disease certainly may be associated with elevated levels and are not something that you're necessarily going to want to correct in an algorithm, but those that have straight physiological aspects to them are something that are going to need to be considered, such as chronic kidney disease when you are trying to diagnose based on a certain level of a biomarker. Increasing, CKD is certainly physiological. BMI is quite difficult. As I've shown, they have physiological aspects, but BMI itself is also a risk factor. There tends to be a decrease in weight prior to a diagnosis. So exactly how to incorporate BMI when you're trying to interpret these biomarkers, I think are still up in the air. The work that has been done to date has focused only on individual chronic conditions, and hence that was one reason for the network and one reason we're so interested in establishing the network, because we need to understand for somebody that comes in that has chronic heart failure, obesity, and chronic kidney disease, how do you interpret the levels of these biomarkers for somebody like that? And one of the working groups that Anne Murray will be talking about tomorrow really has a goal as to trying to develop an algorithm. And then also need to further understand the examination of blood amyloid beta levels in context of cardiac function and medications, and what blood biomarkers may be most appropriate to try and diagnose AD in those patients. I do want to touch a little bit on considerations of race and ethnicity. So there has been a lot of research lately trying to look at racial and ethnic differences in these blood-based biomarkers, but also CSF and imaging biomarkers of Alzheimer's disease. And there are some studies that have suggested that for a given level of amyloid, African Americans are less likely to have tau pathology. Now, despite these studies, there are some other studies that don't find associations. In terms of blood-based biomarkers, again, there are some studies that see racial and ethnic differences, but there are other studies that don't see any differences. And so there's still a lot that we need to understand in this context. And, one aspect is to make sure that we move just beyond comparing race, ethnic differences, say black, white, or Hispanic, white, and to think about some of the reasons that contribute to those differences. So we've just talked about the effects of these comorbidities on the blood markers. Certainly comorbidities are much more prevalent among racial and ethnic minorities, as well as those individuals of lower SES. And so depending on the study and the number of comorbidities, that could affect whether you see a racial ethnic difference or not. Some of the blood biomarkers that have come out have incorporated ApoE and developed algorithms. From a racial ethnic perspective, this is problematic because we know ApoE genotype is not as penetrant for some races and ethnicities as others. And so clinically, if these algorithms are being used, they may be less accurate than using the blood-based biomarkers alone. And I have been in various discussions talking about whether there should be different cut points for different races and ethnicities, not only with the blood-based biomarkers, but also with imaging and CSF. And really, at this point, I don't think there should be. I mean, we all know the experience of using racial and ethnic cut points for EGFR, and they've done away with that right now. I think if there is lower pathology in some racial and ethnic groups, again, we know that ApoE is not as penetrant, and it's very possible that there are other copathologies and increases in other comorbidities, such as cerebrovascular disease, that may be contributing to the dementia. So at this point, I wouldn't promote different ethnicity or different cut points by race and ethnicity. Lastly, just a couple diagnostic considerations to build off what Dr. Whitson had already talked about. And as we talked about a little bit earlier, we know that AD pathology begins decades to prior symptoms and increases with age. And so there is the possibility of a result. Somebody comes in, they have cognitive impairment, they have the blood biomarker. It could be incidental. It may not be the cause of the cognitive impairment, as shown by the example that Dr. Whitson gave. And so, again, it's going to be really, really important not to, one, use the biomarker without knowledge of objective cognitive changes to start with. Maybe there will be screening down the road once we understand these, but to start with. And then also to think about the results of these biomarkers in the context of other chronic conditions. So just because we have AD blood biomarkers now doesn't mean that we should preclude other pathologies that we don't yet have the AD biomarkers for. And so with that, we're really at an exciting time in Alzheimer's disease field. Potential disease-modifying therapies, and we have blood-based biomarkers that are available for clinical use, but there's still a lot that we need to learn yet, particularly in primary care and more heterogeneous populations. And although blood AD biomarkers are promising, there are certainly many questions that remain, and really that's the goal of this conference, is to start addressing those, or think about what is needed, additional research or additional guidelines to address these. As I mentioned earlier, we do need guidelines with both patient and healthcare provider input to understand maybe when they should be used, when they should not be used. So for example, if there's limited life expectancy or other aspects to that. And we also really need to understand what patients want. I think there's a general idea sometimes that patients want to know their ApoE genotype, or they want to know their pathology, or certainly in primary care, there's people that see that there's these blood-based biomarkers and I want to know if I have Alzheimer's disease. But there's also a lot of other people that don't want to know. And so we need to understand some of the reasons behind that and then tailor whether these biomarkers are conducted or not to patient preference. And then lastly, as will be talked about later, there's certainly several ethical aspects that will need to be considered down the road. So thank you for listening, and I'm happy to answer any questions.
Please.
Do you want to?
You go first. I have my generic answers. Questions. No, go ahead. Emory first.
Dr. Mielke, that was a fantastic talk and really cutting edge to make us all aware of the recent studies. My question is, you're looking, when we are looking at the plasma-based biomarkers, you're probably looking at a lot of correction factors that might have to be introduced to make sense of the findings based on race, based on BMI, CKD, and now it also seems like medications could affect it, because if you try to treat CKD with some of the newer medication, that could also offset things. So is there value at some point in having not like a one-time testing, but like multiple testing to make sense of where a patient could be headed? Just wanted to ask about that.
Yeah, I certainly think that's a good idea, rather than using it at one point in time. One aspect, though, I mean, there are studies that have looked at some longitudinal variability, but the vast majority of studies have looked at these blood markers at one point in time, and then, predicting brain pathology, or they try to predict cognitive decline. So I think that everybody can have a peaceful pause. I think there's more work that needs to be done to still understand the intra-individual variability. And now there's some discussion coming out on how fasting status may affect these levels as well. And so we certainly need more information on that before we go in that direction.
Can I go next? Not to interrupt the pause, but we can take a peaceful pause if we wanted to. It will not be peaceful. So there's a couple of questions. One, I think we do need to remember it's one tool in the toolbox, no?
Right.
It's not the magic wand. I live in Florida. It's not Harry Potter. It's one tool in the toolbox. You need to still engage your brain in the discussion with the patient, caregiver, the family. I think we're forgetting a little bit how this fits, even if we had the perfect biomarker. And I think we're getting pretty close to a usable biomarker. I think that's one of the conversations. I mean, we can mine all retrospective data, but at some point, I think we need to make a decision as a field, including all stakeholders. is it now ready to be evaluated in the real world? Because the real world is different from all the research studies, all the epidemiological analysis. So do we have the tool in a supervised, educated environment to start understanding the value? I think, to me, that's one of the conversation. And, the pragmatic science question, yes, there are association with various comorbidities, but currently the notion is we're launching this in a 2 cutoff model with an intermediary zone. Coming back to your question, how significant is the impact actually on performance in that model? Do we need to have the ratio of the total tau, or is, in light of everything else, because the person is not fasted, hasn't slept the night before, the assay is not performing as well, it's not an FDA-approved device. So there's a lot of things which go into that equation. I don't know if the question makes sense, but in mind of everything else, I mean, can we come out of here to say, maybe one of the objectives of the grant is to say, yes, we need education. Yes, we need guidance, not regulatory guidance, but we do have tools which I don't think are really reimbursed. That's one of the other. They're reimbursed at the generic rate, but I can't make a business out of this, maybe for other reasons. But is this at least ready to give it a trial in the real world and try to understand the benefit?
Yes, I think if that's your question.
That was a simple answer.
I think we have to be cautious, and certainly look. I mean, the biomarkers are available to clinicians right now, primary care, specialty care. So I think one big concern is in terms of education, some of these chronic conditions, how to use them, how to take them into context, considering everything else, like you have talked about. So yes, these are going to they are being used right now.
And patients want to use it. I mean, I have a list of 5,000 people more or less after some press releases who email me and say, hey, are you a doc? And I say, I have to disappoint you, I'm not. I can get a license and hopefully become a neurologist, but I can send you there. So they do want to know. So the question is, there is this freight train. Do we keep it on the rail, or do we just say, hey, freight train, do what we do, we go to our meetings, and 5 years later, we come with the white paper, and no one actually cares?
No, this is a reason for the conference. This is happening. It's going to happen. As you said, many, many patients want access to these. I think it does behoove upon ourselves, though, that the lay public does not understand the difference between Alzheimer's disease and Alzheimer's disease pathology. And so as scientists as well, we've got all these headlines that are coming out. Hey, these blood biomarkers are so accurate. Come in. We'll let you know if you have Alzheimer's disease. And we need to do a better job on the media front, too, also putting out some of these precautions as well.
Yeah. Thank you so much, Michelle. I mean, that was such a fantastic overview of the state of blood biomarkers. And a lot of the considerations that you discussed got me thinking, especially regarding social determinants of health as constructs. Because, for example, data from Latin America is showing that, these sort of metrics like socioeconomic status, for example, multidimensional poverty more significantly predicts, cognitive impairment in their setting, even more significantly than age. Sorry, just in a friend. And I just wondered, because race is a social construct, and because of evidence, because you were mentioning how you don't think there'll be need for cut points for different racial or ethnic groups. But I wonder, given the evidence, at least from the brain biomarkers, and also evidence of the dose-dependent effect of ApoE, for instance, across different groups, whether there is current evidence or scope to, within this network, investigate the impact of genetically determined ancestry on how the different blood biomarkers would, predict cognitive impairment, but also be related to brain pathology, because it's very likely that there might be a dose-dependent effect, and it might also be linked to genetic ancestry.
So I agree. I think there's a lot of work that needs to be done in that area. I am part of the Fox study, who's incorporates an African American cohort, about 2/3 of which are in poverty, and that's one thing we're looking at in terms of ancestry on the blood biomarkers. I think, one thing to think about with these blood biomarkers is that generally we use CSF and PET as the gold standard. And we know that the acceptance of CSF and PET in underrepresented minorities and lower SES is a lot less. So those individuals that we have the gold standard on are a very select group of individuals. So in some ways, blood-based biomarkers are really beneficial in that you can reach out and understand in more of these populations, but yet we don't ultimately have that gold standard to assess what they mean. And so just, again, keeping that in mind as we try and think through the interpretation of these.
Hello, I'm Charles Mielke from Wake Forest. Excellent talk. I had a question about the vascular risk factor, so the MI. You didn't speak so much on that, and I was wondering, it doesn't seem to be the same as the CKD example, where it's like a falsely elevated or a lack of clearance rather. Is it more maybe some causation, or that people who have this vascular disease are indeed more likely to get Alzheimer's, or is there another explanation that you've considered?
That's a great question, and I think that's something that there's a lot of research going into right now to try and understand what those associations are. Because you're right, you might have the association because cardiovascular disease has been associated with AD pathology. However, we also don't understand what the peripheral aspects are as well. And, I mentioned associations between p-tau and white matter hyperintensities. We've found that previously published before, as well as with microbleeds. Now, whether that's amyloid beta related and that's why p-tau is associated, not quite sure. But I know Tim Hughes and Sam Lockhart are a study coming out from the MESA as well, where they also see the same thing. So that's where, again, we further need to understand, is there a peripheral aspect that's contributing to it, or is it just, indicative of what's in the brain?
Michelle, you would know this better, but it's my impression that the CSF levels are not different according to MI and CKD. This is really a plasma phenomenon.
Yes.
And so I think one thing that we have to keep in mind is that the p-tau levels go up in AD and not the other primary tauopathies. So there is a biological phenomenon, and we know there's CAA and other kinds of small vessel diseases at higher prevalence in AD. So I think it's really biological. And I've thought about this a lot, and we can't even just control for a few cerebral small vessel disease biomarkers and get away with it. It's really conceptual. One of the things, this is gonna be really hard, but if we wanted to tease apart chronic disease, right? So small vessel disease, which is under the water, and the peak is going to be MI and CKD, we probably need to look at very young individuals with kidney failure or other causes of MI that are not sort of the tip of the iceberg. That may be a way that we can start sort of teasing apart the biological pathways that are contributing to the plasma levels versus organ failure, so to speak.
Yes. Yeah, completely agree with you. I think Nick has a question, and then we'll go on to the next session.
Nick Pajeski from Wake Forest. I was just going to pick up on the point that Charles brought up about the vascular side of things. And I think one of the other things that we're going to struggle with is, while the AD markers are certainly getting ready for prime time, we could debate that. On the vascular side, we're not.
Right.
Right. We've tried to come up with blood-based measures. We have generic things, troponin, BNP, things like that. But there is no marker. Maybe it's white matter hyperintensities. And so I think that's another goal here of, what should you consider on the vascular side when you have an AD marker, and how do we interpret there? Because it's really, we lag behind the AD side with this.
We do, but even if you think about with white matter hyperintensities, you need generally an MRI for that. And there's a lot of people with multiple chronic conditions at older ages that have contraindications to that as well. So what do you do in those situations?